Hi, I'm Dr. Schlang. I'm the Chief Dental Officer of Smile America Partners. Smile America Partners and its affiliated dental practices provide in-school dental care for children in approximately 18 states. Smile America Partners and its affiliated practices treat over 500,000 children annually in school. As Chief Dental Officer, my principal roles are keeping my dentistry current, developing clinical policies and procedures, and spending over half of my time in schools providing care to the children that we serve. Along with me doing that, I work with a team, a Smile America Partners management team that is very talented and enables us to provide good quality care and get very positive reviews from the children who we provide treatment to, their parents, and the schools that these children go to. In this video, I'm going to go over the equipment we use, how we set it up in a school. I'm also going to go over the x-rays, how I diagnose, how I interact with children so that they become comfortable with me, comfortable enough to allow me to do fillings on them and provide other dental services. And also I'm going to go over the dental materials and the techniques that I use, using them to do fillings, extractions, and pulpotomies. Over 95% of their clinical work is fillings. Having said that, let me show you how we set up a dental visit in a school. This would be our x-ray station. Our x-ray station is manned usually by our team lead. She uses a Nomad x-ray, portable x-ray unit to digitally take x-rays, and she has them on her laptop computer. After she does that, she'll give the child a chart that the child will bring over to my station, and this is a treatment station. I can pull up the x-rays that the team lead took on my laptop computer. This is the dental unit that I work with. And in addition to these two stations, x-ray station, treatment station, this is where we have our dental supplies set up. We have a sterilization station. Now what we try to do is we try to have each station at least 6 feet apart from each other. And for our x-ray station, we try to, as much as possible, have behind the x-ray that we take on the child to have it face out to the outside, out the window. If not, we make sure that if there is a wall that's within 6 feet of where we take the x-ray, that on the other side of the wall there isn't anyone working or sitting. And that being said, I'm going to go back to the treatment station and tell you how I basically take care of the children and work with my dental assistant and the child. The thing that we do in in-school dentistry is we have a certain advantage over the dentistry that is done in a dental office. And one of the principal advantages that we have is that the child is being treated in school in an environment that they're very familiar with. The other advantage that we have is that the children come to us in small groups. And in these small groups, they usually have their friends and classmates. So they are comfortable in coming into our visit. It's not like the parent is taking the child to an unfamiliar office and the parent is waiting in the waiting room while the child goes in to have treatment done. In our situation, the child comes in with their friends and is in total view of their friends while we're treating the child. The other factor that we have going for us is that there are no expectations of us to have to provide treatment. The worst thing that can happen is if a child is uncooperative at a visit, we send the child back to their class. The child hasn't lost any time from school, and the parent hasn't been disappointed with a situation where they may have taken time off from work to take the child to the dental office to get the work done. And also, we don't have to do anything to actually do the treatment that visit so that the parent doesn't have that disappointment that the child may not want us to do. So we don't use any anxiety relieving medication. No nitrous oxide, no oral Versed, nothing. We don't give the child any verbal command to behave. We may ask the child if they'll do something for us, but we don't order a child to do anything. We don't order a child to be still and open their mouth and allow us to treat them. The child is a volunteer. And of course, we don't use any sort of physical restraint. So, in review of that situation, we don't set up an instance where we feel that we have to get the work done on any particular visit. Now, with that being said, I'm going to show you our dental equipment, and I'm going to show you how I read the x-rays and do an exam on a child. But before I do that, I want to point out that even though the child is in a comfortable environment and with their friends, what I do for each visit, and which most of our dental teams do, is they set up music in the classroom that we're set up in. So the child walks in to a friendly environment. The child walks in to a place that seems like it's a nice place to hang out with, a nice place with their friends where music is playing. So I think the next step would be for me to introduce you to our child for this setup that we have, and I'll ask my dental assistant to bring in our child.
Carter, are you ready to have your teeth checked?
Yeah.
Great. Very exciting.
Okay. So Carter is our dental patient today. Carter, how old are you?
6.
Say that again.
6.
You're 6 years old. Okay. This is Irene. Irene has been our head dental assistant and trainer for teams that are in other states as well. And she's been with me for at least 14 years. And this is Lupe, and I think Lupe has been with us for a similar amount of time. And we're going to try to show you how we introduce ourselves to the children and how we try to make them comfortable. So we're set up now for me to examine Carter's teeth, to do an exam. But before I do that, I want to go over first the equipment that we use. And so this is the Aseptico dental unit that we use. It has an air-water syringe. It has an electric handpiece. And it has a slow-speed suction and a high-speed suction. It has bottled water and an evacuation pail there, over there. When we use the handpiece has interchangeable heads, one for a slow speed, and when we use the slow speed, that's principally for doing a prophy, and this is the high-speed electric handpiece. And we use the 1-to-1 ratio on the unit for the slow speed and the 1-to-5 ratio for the high speed. Now for the high speed, it can run at a maximum of 150,000 RPMs. We use it at 2/3 speeds at 100,000 RPMs. And that gets to be important when we do our dental procedures. And it's important to use the handpiece at 2/3 speed. After the team lead takes the x-rays, they're transmitted over to my laptop. And what I do to bring up the child's x-rays is I simply either type it, after I've gone onto the computer, I either type in the child's last name, and all the children with the child's last name will come up, or I type in the child's chart number, and those x-rays. The child's chart x-rays will appear by me either typing in the last name or the child's chart number. So what I'd like to do now is to go over what kind of x-rays we take and what we're looking for. So we try to keep the number of x-rays we take to a minimum. But we want, on an initial oral exam, we want to be able to see on 1 or 2 bite wings on either side the distal of the cuspid through the last erupted permanent molar, and we want the interproximal contacts to be clear and not overlapped. We're also, in a child of early mixed dentition, we want to screen for mesiodens between the upper centrals, because if a mesiodens isn't taken out early, it can cause a poor eruption or irregular eruption of the permanent central incisors. On early mixed dentition, we also want to look for missing permanent upper laterals, another common, or let's say a 1% type of developmental anomaly that occurs. Other findings that we look for also are the deciduous, the permanent lower second deciduous incisor, lower second permanent bicuspids are often, I wouldn't say often, it's another type of a 1% occurrence. So those types of developmental anomalies are what we're looking for in early mixed dentition. In late mixed dentition, the principal anomaly that we're looking for is horizontally impacted permanent cuspids. And we want to be able to refer that situation to an orthodontist so that the permanent cuspids can be directed downwards. So we want to be able to get the bite wings I mentioned and screen at an appropriate age for the developmental anomalies that I just spoke of. When I'm looking at the bite wings and I'm looking in approximally, what I usually do is I make note of the interproximal lesions that I see. For instance, I'll have, and we note active caries, we mark it in red on the chart. So let's say I found an MO on A, a DO on B, and a DO on S, which would not be an uncommon occurrence. The children that we see in our program, they are half as likely to have seen a dentist as compared to more affluent children, and also they are likely to have 2 and 3 times as much dental disease as an affluent population. So having 3 cavities per child is pretty much the norm of what we see. It's having a child that has is carie-free and has excellent hygiene is certainly not the norm. So on the chart, as well as what we have for that I could pick up on the X-rays. And one thing I want to point out is that there's a clear view feature of our X-ray software, and it looks like an eye. And when you read X-rays, always make sure that you've pointed the cursor to it and clicked on the clear view, and you're always reading the X-rays under clear view. Another let's call it developmental anomaly that we see quite frequently is ectopic eruption. Sometimes when the upper permanent molar is trying to come in, instead of coming in, it erodes into the upper deciduous second molar. And it looks alarming, but in over 2/3 of the cases, that self-correct. So we usually don't refer that out until we've seen the child for an extra 6-month recall and the problem hasn't resolved. So when we see ectopic eruption, don't get alarmed. It doesn't need to be referred out unless it shows up. It hasn't self-corrected on the next recall. On the child's chart, it asks for caries risk, and it's listed as low, moderate, or high. I have a pretty simple way of looking at that. A child's caries risk is low for our purposes if the child doesn't have tooth decay, has not had tooth decay, and there are no white spot lesions or any sign of tooth decay, and there is no plaque buildup. So the child's keeping their teeth clean and there are no caries. The caries risk is low. Moderate means that there are no active caries, but the plaque is built up. There's some plaque buildup. So if the child hasn't had caries, but you see if the child is not keeping their teeth perfectly clean, their risk of caries is moderate. For high risk, that means that the child has either previously had tooth decay, has current tooth decay, or has white spot lesions noting a decalcification. We also have categories on the chart that we fill out for good, fair, and poor oral hygiene. Good means no plaque buildup. Fair and poor, well, that's relative. A lot of plaque buildup, fair hygiene. Even more plaque buildup, poor hygiene. We also ask for gum status, tooth alignment, and soft tissue. For tooth alignment, I really don't like referring children out to an orthodontist until they have their full permanent dentition. However, some children have had problems with thumb sucking or tongue thrusting, have narrow arches, and need either a palatal expander or they need a tongue crib made. And certainly those children we want to refer out to orthodontics. Minor crowding on a young child is really not a real concern, but if a child is, let's say, prognathic, or if a child has major crowding with the permanent teeth coming in, that would be another indication for early referral to orthodontics. We don't want to interrupt seeing the child for preventive care or for restorative care when we do refer out for orthodontics. So we have different categories for seeing children. 1A means we've completed the child's treatment on the first visit. 2A means we haven't completed the treatment, but we're coming back for treatment. 2B means that we don't see a possibility of handling the child in the future because of anxiety or extensive decay, so we're going to refer the child out. For orthodontic purposes, I like to keep the child as 2A, but to write down in a note to the parent that the child has crowded teeth or a narrow upper palate, and you recommend that the parent take the child to the orthodontist. Medicaid in most states only covers orthodontics for handicapping occlusion. And sometimes the cost of orthodontics is out of the reach of the parents. So naturally, this is a recommendation to the parent, and sometimes the parents can do it, and sometimes they don't have the financial means to take care of the orthodontic problems. We have an urgent care category, which is category 3. Sometimes if you have facial swelling and the child doesn't allow you to treat it, you'll want to make a special note that this child is 3B, and we will case manage, the Smile America partners will case manage that child into treatment within the next 24 to 48 hours. I don't see any other parts of the chart that I need to fill out right now. So after I've looked at the x-rays and I've charted the interproximal decay, I hand the chart over to my dental assistant, and then I complete the process of doing the oral exam. But before I do that, I want to go over how I relate with the child and try to get the child to be comfortable with me so that I can provide treatment to the child. So when I see a child, I try to be as friendly as I can be, and what I think a child's looking for from me is for me to be confident, calm, and basically have the same sense of humor as the child. if the child sees that I'm someone who likes to have fun and is calm, they generally feel that they can trust me. So if this was the first time that I met Carter, I would say, "Hi, Carter, how old are you?"
6.
Okay, Carter, I've got a few questions for you. One is, why did the kid throw the clock out the window?
He wants to see time fly.
Excellent. And for those of you who want to be able to easily break the ice with kids, I suggest laugh out loud jokes, and they're easily ordered on Amazon. Carter, before I get to examining your teeth, I got another kind of like theoretical question for you. One is, do you like candy, cake, cookies, and ice cream?
Yes.
Do you like them a lot?
Yes.
Okay. Supposing I told you that if you cut out candies, cake, cookie, and ice cream, that you probably would never get a cavity and wouldn't have to get a filling. Would that be enough for you to say, yep, I'll cut them out. I'm not going to eat any more candy, cookies, cake, or ice cream?
No.
Is that a firm no? Okay. Do you think your friends would say yes to giving up candy, cake, cookies, and ice cream?
No.
Okay, that's kind of what I thought. So Carter, I'm going to examine your teeth soon, but before I do, I want to show you some of my helpers that I use when I do examine teeth. So on any given day, this can be either Mr. or Mrs. Thirsty. Try it out. It's like a reverse straw, and that helps get the saliva out. And I have this, and his name is Mr. Wind. Now, do you know why his name is Mr. Wind?
Why?
Because he's very windy. And it makes it feel like there's a hurricane going on inside the room. Got it?
Yeah.
What's his name?
Hurricane.
No, Mr. Wind. No, it's not hurricane, it's not windy. What's the name? Mr. Wind.
But you
Okay.
could use those other choices, right?
Mrs. Thirsty, Mr. Wind, or Mrs. Wind, and Mr. Thirsty. Okay? All right. So anyway, I find that Mr. Wind is very helpful in kidding around with a child. It makes a child more comfortable with me. And before I examine a child's teeth or I work on a child and do procedures, I want to get a smile. I want them to be able to smile. Now, Carter, which of these phrases that I say do you like the most? Open up and let me look at your teeth. Or, no, there's more choices here. Or, open up and let me look at your teeth, okay. Or, open up and would you let me look at your teeth? Please do it for me. Which one sounds the best to you?
The first.
The first one. Open up and let me look at your teeth. So when I work with different assistants, and I work in multiple states, a lot of the assistants I work with, they say things that are pretty innocent, but sometimes when a child is right on the borderline of being anxious, it could be a problem. So I prefer that the assistants don't say, okay. And what I mean by that, I prefer that they say, Dr. Schlang's going to examine your teeth. Open up. I prefer, or Dr. Schlang's going to count your teeth. I don't really like them to say, Dr. Schlang's going to count your teeth, okay? Or I'm going to polish your teeth, okay? Or I'm going to put fluoride on your teeth, okay? And the reason that I personally don't like that is it gives the idea to the child, or it may give the idea to the child, that it might not be okay. So when I work with dental assistants, I ask them if they could try to hold down the okay. And sometimes they'll say something to a child like, could you put your hands down? Well, can you do it for me? It's not a personal thing that they should be doing for one particular person, because I'm thinking like, wow, maybe would he do it for me or only for you? So anyway, these are perhaps nitpicky points, but I want to point out to you that sometimes with an anxious child, it can spell the difference between the child cooperating and not cooperating. When I have a very anxious child, I try to do all the talking because I know that each word is important. So before I start a visit, usually I go over these things with my dental assistant, and I also point out to my dental assistant that if I'm going to give local anesthesia, I'm not going to have a conversation about it. I'll give a cue, like I'll say lidocepticane, or I'll say, no, take that back. I'll say topical septicane, and that means give me the topical, set up a syringe with a short 30-gauge needle, and because I'm going to administer local anesthesia. So let me go to doing an exam on Carter, and I'll need a mirror. Thank you. Thank you, Lupe. Now, when I do an exam, I don't wear my reading glasses. I wear my loupes. And my loupes are the most important thing that I have to do an exam, because when I do an exam, I'm using magnification, good lighting, and dry teeth. Without the magnification, I really can't do a good exam. Without the magnification, I really can't do dentistry the way that I want to. In the first 20 years of my practice career, I didn't wear loupes. I started wearing loupes about 20 years ago. A dentist who's in their 20s and 30s probably can get away without wearing loupes, because one of the main reasons for wearing loupes is for the dentist to develop good posture. However, once you're in your 40s, your close vision gets poorer and magnification becomes essential. For approximately the last 20 years, dental schools have required their dental students to wear loupes. So if dental students have been required to wear loupes for the past 20 years, there are very few dentists who are under 45 who are educated without loupes. Anyway, I wear 4-power loupes with a pretty wide field. It lets me see 3 or 4 teeth in my field of vision. And in order to do the dentistry the way that we need to do it in school dentistry, loupes are essential. And my loupes have a light that is part of the loupe setup. For those of you who don't have lights that are part of your loupe setup, we have headbands that that contain good lighting. So to do an exam, I put my loupes on, or to do anything, to do any dental procedure, I put my loupes on. And I want to make sure my light is focused. And I can dry the teeth with air. Now, most times, I'm not going to do my exam with an Explorer. Explorers are no longer used to probe teeth for sticks. That damages teeth. What Explorers are used now is to debride teeth. If you have debris in the grooves, you use an Explorer so you could clearly see the grooves, pits, and fissures of the teeth. Anyway, I gave my pitch on the loupes. I can't emphasize enough how important loupes and good lighting are to doing good dentistry. So let me do my exam. Drying Carter's teeth. I already noted the pretend interproximal lesions, and when I was looking at the x-rays and marked them in red. So now I'll call out the exam. Carter has has 3 A, B, C, D, E, F, G, H, I, J, 14, 19, KLM, N, 24, 25, R, QR, ST, and 30. He has no caries. And his hygiene is good. However, let's say I discovered that Carter had plaque on his teeth. Well, let me back up a little bit. I'm going to ask you some questions, Carter. Okay? And this is the answer. Okay? So how many times a day should you brush your teeth?
2.
For approximately how many minutes?
2.
And how many times should you have a checkup with the dentist per year?
2.
Perfect. You get 100% on your quiz. Okay. Do you know how you could tell, or let me show you how you could tell if you're brushing your teeth good enough. I'm going to take your fingernail, I'm going to scratch your tooth right on the neck of your tooth. I'm going to scratch this tooth on the neck. And what do you see on your fingernail?
White.
Okay, you see white stuff on your fingernail. The white stuff is plaque. Plaque, even though it looks innocent and it's just a white little film, that's what causes cavities. Because there are little bugs in the white stuff. They eat sugar, they spit out acid. The acid puts a hole in your tooth, and that's called a cavity. You want to avoid cavities. What you want to do is keep the white stuff off your teeth. So if during the day you scratch your tooth and you get white stuff under your fingernail, that tells you either at night when you brush your teeth or in the morning or both, you need to brush better. Okay? Now for Carter is 6 years old. He's getting to the age where he can brush his teeth on his own. But what I recommend to parents is that until a child is 7 years old, that they brush their child's teeth for them. As far as this test, which I call the scratch test, I think it's probably the most effective thing that I have found to enable children to determine whether they're brushing their teeth enough, and also to explain to them how a cavity happens. Brushing their teeth twice a day for approximately 2 minutes each time tells them what to do, but it doesn't really tell them exactly why. If they know that the plaque that they can scratch off their teeth is the cause of a cavity, if they know that the plaque produces an acid and the acid can put a hole in their teeth, decalcify, demineralize their tooth, and they know how to check for that during the day, that gives them an excellent tool to understand that if they keep their teeth free from the plaque, they're very unlikely to get a cavity. Some of you may be thinking, well, that doesn't sound very hygienic for a child to be doing that during the day. Having seen the number of children that I see, or have seen over the past 14 years as the dental director, I can tell you at least half of the kids I see, they bite their nails. And that's not so hygienic either. So from my perspective, scratching the child scratching their tooth during the day to see if they've been brushing good enough is acceptable. It may not be for you, but it worked. I've been concentrating on trying to change the child's brushing behavior and making it so that I can come to visits and see their teeth plaque-free because they've been brushing enough by promoting the scratch technique. Don't know yet if it's how successful it is, but it seems like a good idea for me. So let me continue with my exam on Carter. So I think I gave you all the erupted teeth, and that there's no existing fillings in his mouth, and he doesn't have decay. But he needs sealants on 3, 19, and 30. Now 14's erupted, but there's an operculum over the occlusal surface, so 14 will seal at another time. So Carter, you need sealants, and I want to show you what I use to apply the sealants. This is what we use to apply sealant. Now, some kids, when I show them this, they think, is that pointy? Is that a shot? Was that any thought that you might have?
No.
Good. So let's say you were anxious and you were afraid of what this was, and it certainly doesn't look scary to me, but for 4- and 5-year-olds, and even sometimes older kids, they think that this is anesthesia. So what I do for them, if they'll let me, I'll put the sealant material on their fingernails. If they don't let me, I'll put the sealant material on my own fingernail. So I'm going to put sealant material on Carter's fingernail, and what I do is I put a dot, but I need another tip. Nope, that's not going to work either. Light blue tip. To put on sealant material, we use a 25 gauge tip. Also for our etch, we use a 25 gauge tip. This is our etch. And 25 gauge tip is light blue. For everything else, we use a 22 gauge tip, which are black. This is the etch I prefer. It's called Ultra Etch by Ultradent. It's very creamy. However, like most etch, does not have a good taste. This is the sealant material. It's not a shot. And for kids who are afraid of the syringe, what I do is I put a drop on each fingernail. Then I ask for that to be set up. And Carter, touch those. And how do they feel?
It feels weird.
Does it feel hard?
Kind of.
And it came out liquidy, and now it's hard. So that's what a sealant is. Also, that's kind of what a filling is. Okay. So now that I've shown Carter that a flowable syringe is not an injection, it's nothing to be afraid of, it's not a needle, I'm going to ask Irene if she'll give me the treatment plan that I gave her for Carter. So this is a Post-it, and when I do treatment, I like everything that I'm going to be doing on the child to be put on the Post-it. And then after I'm done with treatment, I know what I've done by looking at the Post-it, and I'll either write up the chart personally using the Post-it to fill in the fillings that I did, or I'll have my assistant write up the chart, and I'll review the chart looking at the Post-it. So for me, it's very important that all of you, after you do an exam, that the assistant write up the treatment that you may be performing that day on a Post-it. Now, depending whether the child seems calm and I seem to have a good rapport with the child, is usually the determinant of whether I'll do the child's restorative care at the same time that I do the exam. If I can, I want to do that because the child, I know if I spent the time getting the child comfortable with me, the child will give me approximately a half hour of time if I can give the child a comfortable experience while I'm getting the dentistry done. I use a technique with the electric handpiece to be able to do approximately 80% of the fillings that I do without local anesthetic and without hurting the child. The other 20% of the time, I'm using local anesthetic. So in order to evaluate whether I'm going to use local or not use local, it's generally the procedure that I'm going to be doing and how old the child is. If a child is over 8, a child is usually very acceptable to local anesthetic. If a child's under 8, the needle is a big deal, and they want to avoid needles as much as possible. So for Carter, let's say I was going to use local anesthetic on Carter. What I would say is topical Incepto, please. And that's a cue to my dental assistant. I think it'll just blow up. That's a cue to my dental assistant to give me topical anesthetic and to set up a syringe with Septocaine, it says Articaine, and a I use 30 gauge short needles for giving an anesthetic. So considering that I have a good rapport with Carter, after I've received my post-it with the treatment plan, I'll simply say to Carter, hey Carter, I've got some sugar bugs to chase in your mouth, so what I need for you to do is tilt your head back, close your eyes, and no peeking. And I will put the topical on Carter's mucosa and gingiva. And I'll probably do that for at least a minute. And then for infiltration, I usually use, or I almost always use, Articaine. And the reason why, for infiltration anesthetic, Articaine penetrates bone better than lidocaine does. For a mandibular block, I'll use lidocaine for the mandibular block because the mandibular block isn't dependent on the anesthetic's ability to penetrate bone. So if I'm, let's say, going to try to anesthetize the deciduous molars, what I do is I pull the upper mucosa tight, and the way that I grab my syringe is underneath the headrest, and we need to put that back on, and have my dental assistant pull off the needle cap. And I pull the mucosa tight, and I keep chanting, no peeking, no peeking, no peeking. And then I'll penetrate the mucosa very slightly, and then push with my thumb very slightly. And before I give any other kind of push, I'll count in my head 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then I'll push. So I do that for any infiltration that I do. And usually if I'm going to infiltrate for getting Articaine anesthesia for the lower deciduous molars, I will pull the mucosa taut and do the same thing. Now, what I find with the children is that they are less disturbed by the upper one than they are on the lower. And I find that once I've given the upper injection, that let me hang on to this for just one moment. Once I give the upper injection, if they feel the lower a little bit, they give me a pass because they know that the upper went so well. I want to show how I give my mandibular blocks. And the way I do it, on the left side, open Carter, I feel the ascending ramus with my thumb. And then I go approximately a ½ inch distal to my thumb, come over the opposing mesial of the first molar, or approximately, penetrate, push, count, wait, and try to get to the bone, and then I can push, count, wait, and know that I'm not injecting into muscle. On the right side, open wide, Carter, I put my finger, my index finger, on the ascending ramus, and I come in from the opposite side, and I come in, I have the needle go in approximately a ½ inch distal to where my index finger is palpating the ascending ramus. As far as what my dental assistants are doing at that time, I encourage my dental assistants to be ready, but not to put their arm over to prevent the child from having their hands go up. And the reason why I do that is because sometimes a child is peeking. And if the child, even though I'm chanting, no peeking, no peeking, no peeking, the child's peeking, sometimes the hand going over the chest makes them jump because they're going, uh-oh, something bad's going to happen. So that's the way I give local anesthetic. Now, I spoke about 80% of the fillings that I do, I'm not using local anesthetic. And I'm not going to need Carter for this part, so you're free to hop up and go use your iPad or whatever.
Can I go eat candy?
Wait a minute, wait, before you, I like that question. Could I go and eat candy? I forgot about certain props we had. So let's see what we have in the way of props. Now, we have M&Ms, we have Cracker Jacks, and for those of you who are wondering how we got Carter to come today, you know, it was like, do you want to go play? Do you want to come do this video with me? We have Red Vines. Wait, you're almost done. You're working now. Okay. Starburst. Out of these four, which is your favorite?
Red Vines.
Red Vines for you. How about Starburst? You like those?
Yes.
Take it. How about Cracker Jacks?
Not really.
M&Ms?
Not really.
Okay. Well, you got two you like. My point with that is kids really like candy, and you could, if what you're bribing them with the candy for is if it's reasonable, they'll go for it. Even come and do a video